Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. Today we're going to be talking about the thyroid. This is a question that we get all the time in clinic. Patients with questions about do they have thyroid disease, do they not, what do we do about it? So we're bringing on endocrinologist Dr. Emily Brennan from LMC London to answer all of our questions about thyroid disease today. And we'll be chatting with Dr. Brennan right after this message. All right, welcome back. Again, I'm pleased to be joined today by Dr. Emily Brennan. Dr. Brennan is a community endocrinologist here in London and works at LMC London. So thanks for joining us, Dr. Brennan.
Thank you so much for having me. I think thyroid issues are a great discussion topic because it's a really common issue that patients have, and we're seeing it all the time.
I'm surprised actually when I was thinking about who should I bring on this week, and I thought about the thyroid, and it struck me that I haven't actually in the years we've been doing the show come around to the thyroid, even though it's something that I'm probably asked about multiple times each day by patients, and I know a lot of patients have a lot of questions about it. So I'm really excited to dive in here. So let's start just with kind of a basic question for you. So what is the thyroid, and kind of what does it do?
The thyroid is an important gland that's actually located in our neck, and it's kind of butterfly shaped. And it is one of the most important organs to control our metabolism. And when we think metabolism, it's really our temperature regulation, our heart rate, blood pressure. So it generates something called thyroid hormone, and that hormone acts on every other organ in our body. So it really is a master controller gland in our body.
And patients will often kind of come in having put their symptoms into Google, and it comes out with under symptoms of low thyroid. It'll have 20, 30 different symptoms. And a lot of patients will say, well, these symptoms kind of jive with what I'm experiencing. Obviously, you've heard this in practice as well. So what are some of the symptoms of hypothyroidism, underactive thyroid?
Underactive thyroid. So the most common things we see it's overall fatigue, but it's kind of different than just our normal day-to-day fatigue. It's someone who's really seeing persistent for weeks to months where they say, I just really don't feel like myself. And really you have to compare to your peers because, we're different at 21 compared to where we're at 51. So kind of looking at other people of your age group is kind of helpful. So fatigue, sometimes weight gain, cold is often a very common issue, and constipation. So it just generally everything is slowed down because we're not seeing as much thyroid hormone.
And I know, there are different levels, obviously, of kind of underactive thyroid. And I've had a few patients myself who've come in with severely underactive thyroid, levels that were quite impressive. And patients can actually look different. I'm not sure if you've seen, I'm sure through your experience have seen patients where there's actually a physical change to patients with underactive thyroid.
Absolutely. It can be very striking that there often is a lot of fluid retention and significant change in our skin as well, that of significant dryness and motor slowing. They actually, when we check reflexes, they actually are not nearly as brisk as what we would expect to see. So everything in the whole body is just sluggish and slow. And if it is untreated, it actually can put us at high risk of, we can't, fight that pneumonia or fight that flu virus. So it does have significant consequences if it is left untreated for too long.
So if a patient comes in and they're suspecting they have underactive thyroid, or their clinician is suspecting it, what kind of tests are done?
So usually we start with blood tests, and we're very fortunate that the blood tests that we have today are extremely accurate. So the test that's commonly done is called the TSH, and that's really looking at what our brain is actually the master controller, and it tells our thyroid what to do. So we can check the brain levels, and it's a little bit confusing for patients sometimes because it's like a thermostat level. So the level for the TSH says high, that means that you don't have enough thyroid hormone in your body because your thermostat is calling for more, and yet your thyroid isn't able to make it. Then if that is abnormal, then your doctor can order something called a free T4 to confirm that your levels are actually low.
So we do that TSH level, and it's elevated, and someone's 3 levels are elevated, then we would go ahead and treat. Now, I know you and I probably have had multiple examples where patients have been convinced that they have symptoms. They've got the checklist out, and they say, yeah, I've got 10 symptoms of low thyroid, and the TSH is normal, doc, I'm convinced that I have this. The test must be wrong, or are there other tests that we can do that would confirm I have this? What do you say to those patients?
Yeah, and this is a very challenging thing because unfortunately there is so much overlap with the thyroid symptoms with other conditions. And so it's, about, talking to our patients in a really nice way to kind of help them understand it. The tests are incredibly reliable. We are very fortunate. There are a few scenarios if someone has had pituitary surgery or a very severe head injury where they had been in critical care ICU. So there are a few patients who it's not a reliable test, but for most people, we trust those levels. And so we really want to then say explore other reasons because unfortunately fatigue is one of the top, it's the #1 symptom of most conditions, whether we look at lupus or diabetes or arthritis or even if it's, more depression. So I think it's just important to kind of, put that aside and then restart out and explore other areas because we don't want to blame the thyroid and when we actually may be missing another condition. So I think that it's just we're not done with the symptoms, but then moving on and exploring other pathways.
That patients come in normal thyroid. Friend tells them, ask to have your free levels checked because they could be low, and with a normal thyroid, with a normal TSH. What again?
So again,
What's
same
the response to
scenario.
that? Yeah.
In general, the TSH is the best test. I look at it like climate. So basically the TSH is telling us what the climate is. The free hormones, they go up and down like weather. Sometimes it rains, sometimes it doesn't rain. So they are actually not very reliable to actually see what your thyroid function is. The TSH tells us the most information. From time to time, it can be beneficial to check that for a patient, but in most scenarios, it really is that TSH is just like if we would check your blood sugar, if it was normal, we would move on. We wouldn't say, oh, you need to start insulin now. And so it just sometimes reframing it is when, why not trust the blood test, but really kind of understanding that patient and understanding what they're coming from and exploring where other concerns may be.
Yeah, absolutely, and especially other conditions, right? Look at we've done a few episodes on sleep apnea. Probably a far more common cause of fatigue than hypothyroidism. So making sure we're not kind of putting our blinders on, and even though a lot of symptoms may be overlapping with hypothyroidism, a lot of conditions also have those symptoms as well. So for the patient who gets the blood test done, is confirmed to be hypothyroid, so to confirm to be underactive, how do we go about treating that patient?
Absolutely. So sometimes when we have that, people can actually just be monitored. Not all patients need to start on thyroid hormone right away. So just so that way people know that it's not automatic, but often that will progress over time and people will need medication. We're very fortunate that there are treatments and they're very good treatments. It's called thyroid hormone or levothyroxine, and it's identical to what our own body makes as thyroid hormone. So we don't really think of it as a medication so much as hormone replacement. There's really no side effects to the thyroid hormone, unless of course we don't have the right dose. If you're on too much, sometimes people can what we call hyperthyroid, or if they're on too little, they may not see complete resolution. But that being said, that even though the treatment is very effective, it may not completely optimize or resolve all of someone's symptoms as well. And I think it's important to kind of still remember that hypothyroidism, it is a condition or it is a disease. And so a pill doesn't completely replace what our organ would do because we can't have that nuances in the dose if you're ill or if you're exercising. So it goes a long way to resolve so many of the symptoms we may not feel exactly as we felt before starting on thyroid.
And how do we decide on dose for patients?
So the dose is a little bit dependent on our age and on our weight. So usually the starting dose is based on somebody's weight, and then we monitor about every 6 to 8 weeks with blood work to make sure that the dose comes into line, and we are able to check it on blood work as well.
Perfect. And again, we kind of come back to the patient who had some symptoms. Blood work showed that they're hypothyroid. We put them on the replacement. We check their blood work. Blood work's now normal. They still don't feel well. They still have some residual symptoms. What do we do? What do we do in these cases?
And that's a common issue as well that we see because again we were struggling with fatigue, and it's such a it's such a common issue, but it just has there's so many things that can contribute to that. So what we usually do is then kind of, relook at, could there be other factors, whether someone's B12 or iron or other, kind of start at vitamins and other hormones. But then usually we will say, make sure that the dose is optimized. And often people will feel a little bit better being on slightly more thyroid hormone, but still within the target range. There's a sweet spot for thyroid. That's what I like to tell people, because too much, we don't feel that great, and too little, we don't. So we're truly trying to find someone's sweet spot, but it does mean a little bit more blood work more often for people to kind of find that number.
The medication for replacement that we use, I know some patients will be on the same dose kind of every single day. Some patients may be on a different regimen where they take kind of extra pills at certain days of the week. Any rhyme or reason, or all of these reasonable options?
So we're really fortunate because again, we have a lot of flexibility, but we don't all fit right into the box in terms of what your dose will be. So sometimes when we do a dose increment, people will go from, say, 125 to 150, and that 150 is too much, and yet 125 was too little. So often we'll just do an extra half pill on Sundays, for example, or we'll just do very small tweaks, because some people are very sensitive to thyroid hormone dose changes. The next person, they don't seem to it doesn't matter how big of a change, they don't notice it. So I always think it's very important to go very slow, but it has a very long half-life. So that's why people can actually take it once a week. They could take all their medication once a week if they find it challenging to take it every day. Sometimes it can lead to a little bit of inconsistencies, but we are able to do small changes that one day a week you can do a different dose compared to another. That's all very normal. And again, it just lets us, find a dose that's not exactly that comes out of the box, basically.
Coming back to the patient who we've diagnosed with hypothyroidism, put on supplementation. Again, they say that they've still got some residual symptoms, whether it's fatigue or concerns about their weight. And they come in saying, well, my friend is on something called desiccated thyroid. So some natural thyroid hormone that they're on, and they feel way better on the thyroid. Can you put me on that, doc? I know we've both probably had that happen many times in our careers. What is this, and kind of what's your response when patients bring this up?
So desiccated thyroid hormone is what we used before we had the synthetic version that's identical to the kind of human T4. Desiccated thyroid usually it comes from a porcine source, and it has two components to it. It's about 75% T4 and about 25% T3. Now, our body, it does make both, usually in a more of a different ratio than the porcine desiccated thyroid hormone. And so that's where some of the issue comes from. So our body, we know we make T3, and then the only real concern when that happens is if somebody was in ICU, which is a very different setting than someone just coming into our office. So we know people have T3, but it's not something that we can easily test someone's conversion. And there's always some thought about that, if that's kind of what's impacting the fatigue. So a lot of people are looking to desiccated thyroid hormone as a possible, answer to this. There are some studies that they're relatively small, and there's some benefit that they say about maybe 40 to 50% of people will feel some improvement in their energy levels when they are on it, and the other half really didn't see any difference. I will use it. It just depends on the scenario, and the importance is that we cannot become hyperthyroid. The problem with hyperthyroidism is it increases our risk of heart irregularities, like something called atrial fibrillation, and it's also very hard on our bones, so causing osteoporosis. And sometimes these are risks that don't feel in the moment so important, but these are something that over the long term can have very significant impacts on people's lives. So desiccated thyroid hormone can be used in a patient who is going to be closely monitored, and we need to ensure that they're not on too much thyroid hormone. And that's the problem with T3. The vast majority of patients do very well on levothyroxine. So it really is a rare subset. And usually these people are going to be referred on for, to endocrinology kind of for that fine tuning and so seeing, can we again explore other options and not just blame it on the thyroid.
For sure. And the one thing I tell patients too is that there's a significant placebo effect for those individuals in their lives who have taken desiccated thyroid, who note feeling better, that we know that for these non-specific symptoms, if they take a sugar pill, they may describe feeling better, and studies aren't as reliable. And the taking the natural thing, there's a reason why we take aspirin out of a bottle from the pharmacy and don't chew the bark off willow trees, is that we've been able to kind of
and it's not like if you're
time.
natural, I'm like there's nothing natural about having like porcine derived hormones, like that's not
Correct,
our
yeah.
makeup, and
Yeah.
so it really it's not the preferred option. Sometimes patients are pretty adamant about it, and it's kind of making sure that there's a very informed discussion about this, but it's just that too much is not a good thing, and that's what is interesting about it, is there truly is a sweet spot for it, and usually there's usually other factors that need to be addressed there.
For sure. And the neat thing about levothyroxine, unlike most other meds we give, is it literally is an analog of what's already in our body, right? So
it literally is. I don't even know if I have another example. Like insulin isn't identical, and yet thyroid hormone is actually identical to what we have. And so it really is, it's remarkable that we have such a great thing. It's a game changer medication, and we don't think of it like that. And yet it's changed, a large portion of society have hypothyroidism, and they do so well.
For sure. We're going to take a quick break and come right back after this message. All right, welcome back. Again, we're joined by Dr. Emily Brennan, local endocrinologist at LMC London, to talk about thyroid disease. So we've talked a lot about underactive thyroid and hypothyroidism. So we're going to switch gears to talk about hyperthyroidism. So these are patients who are presenting with symptoms of an overactive thyroid. So can you tell us a little bit about kind of what symptoms they would present with and how they would feel?
So it's the complete opposite, actually, where people feel extremely hot, have heart racing, often very frequent bowel movements, and just incredible, shakes, tremor, often weight loss. So it truly is the complete opposite. And we see quite a big spectrum where some people can have, the levels can range from being 25 or they could be 100. And so it's very varied in how people appear.
How frequent would you say it is compared to an underactive thyroid? Like how what's a proportion of patients who get this over level? Yeah.
Yeah, so it probably is about 10% compared to when you look at the first thyroid patients. It doesn't come up nearly as often, which is kind of interesting. And there's a significant predominance for women as well. So it would tend to be a 9-to-1 ratio of women to men with hyperthyroidism and hypothyroidism.
And what kind of tests do these patients need, both for their initial testing and then other imaging tests that we do?
So it helps us sort out the cause. At the end of the day, a lot of the treatment is the same. We still are able to use medications initially, and people can go on to more advanced therapies. But right off the bat, it always will start with a blood test, and it's the same, the TSH levels. And then in this scenario, we actually do need to check the free hormone levels, because we cannot tell how hyperthyroid you are if we don't have the levels. So the brain basically shuts off and says, I don't need any more heat in the furnace, and so I don't need to make any thyroid hormone, but the thyroid is working on its own. And so we need to do the blood test, but then often we can do special blood tests to look at antibodies, or there's a special test where we can do what we call a thyroid uptake and scan. It's a nuclear medicine test done at the hospital where you actually have radioactive iodine and you drink it. It doesn't hurt or anything like that, but then it lets us take pictures of the thyroid gland so we can see the cause. Is it the whole thyroid that's lighting up? That's an autoimmune condition, also known as Graves' disease. Graves is the last name of the person who discovered it. Or is there spots where people can have what they're called toxic nodules, and it's kind of a bad term, but these nodules are making extra thyroid hormone, and then this can cause the same symptoms.
And so Graves toxic nodule treated differently
So in terms of the initial management, no, actually. Usually both require medications they're called anti-thyroidal medications. Methimazole is one of the most commonly used, and it basically can help with shut down that inflammation and that autoimmune component if it's Graves, but it lets us control the thyroid levels. It's putting the brakes on the gas, basically.
And what kind of follow-up do these patients need? So they're put on meds, they feel better. How long do they continue it for, and what kind of follow-up do they need?
So usually they have monthly blood work, at least until we see that the levels are quite stable. And we want to use the lowest dose that actually keeps the levels in check. So there's quite a bit of blood work at the beginning, and then it gets significantly reduced, depending on the cause. So if it is the autoimmune form like Graves, most people need treatment for between 12 and 18 months. And then we're hoping that people will go into remission. And by keeping it a little bit more sustained, we have a better chance that someone will go into remission. If it's nodules, they tend to be what I call well-behaved. It's usually just low amounts all the time. And so those people often just need a very low dose and are more easily maintained. That won't go into remission because it's always just doing a little bit low grade.
Last thing I want to talk to you about today is thyroid cancer. So I know I'm sure some viewers may either family or friends have had thyroid cancer and have gone through that process. So can you tell us a little bit about kind of what first of all, I guess we'll ask, how is thyroid cancer diagnosed? So either incidentally or do people palpate it? And then what kind of cancers are there?
Yeah, so that's a great question. So most people actually it's found incidentally because we're doing a scan for another reason. Sometimes people are having tests on their carotid, and then they just happen to catch the thyroid and they see that there's a little nodule there, or they're having a CT scan and then we find this. So or sometimes people do identify it themselves. Sometimes it's when they go to the dentist because people are being looked at carefully on their neck. So the best test is an ultrasound to actually see what's happening and to look at the nodules. And the ultrasounds and the radiologists can give us the characteristics of the nodules. And they tell us a lot about how worried we are about could this be cancer or could this just be a benign or a non-cancerous nodule. About 50% of people actually do have thyroid nodules. We don't know exactly why they happen, but we think it's probably due to viral illnesses. 90% of these nodules are completely benign, if not even more. So we look at the characteristics. Your doctor will use that information and decide, the next step, do we monitor this nodule? Usually if it looks reassuring, it looks very low risk or benign, usually people would have ultrasounds sometimes once a year for 5 years. If they're more worrisome, then what we do is actually do a biopsy, and this is done with an ultrasound. So the radiologist can do the ultrasound, see exactly where that nodule is, and then they do put a very small needle to take some samples of it. And so the pathology is what tells us then if this is a cancer versus a benign nodule.
And for those who unfortunately are found to have cancer of the thyroid, which again is a small subset of those with nodules and a subset of those who actually needed a biopsy. What kind of things are done for these patients in terms of management? So surgery, radiation, what kind of things could these patients expect?
In most cases, the first step is surgery. And I would say the honest answer is in most cases that's the full treatment. People do extremely well, and they usually try to take half the thyroid out, just the half that is impacted, and then we want to leave the rest of the thyroid in because that way you can still make your own thyroid hormone and you won't need medication long term. Some people, if it is a more aggressive form of thyroid cancer or there was more involvement, then they would take the whole thyroid out. And some people do need a special kind of iodine treatment. It's a drink. It is called radioactive iodine, and it's meant to destroy any microscopic thyroid tissue that's remaining. So it's technically a chemotherapy, but it is not in the same, what we often are thinking about chemotherapy, where people don't lose their hair or any of those types of things. Usually it's a one-time dose. And then we very carefully monitor people's thyroid levels to make sure that we reduce any risk of recurrence as well.
Perfect. Again, thanks for joining us and giving us so much helpful information about the thyroid today, Dr. Brennan.
Thank you so much for having me. It's really been a pleasure to discuss this with you, and I hope it will be helpful for your viewers.
Again, thanks to Dr. Brennan for joining us today and giving us all of that helpful information about the thyroid. And really, if there's one prevailing message I would give to you today is that if you think you have symptoms of thyroid disease, hypothyroidism, and you get your blood test done with your doctor and they tell you that your TSH is normal, just take their word for it that your thyroid is indeed normal, and other further testing or treatment really won't be too helpful. And until next time, stay healthy.